Our next speaker is Professor Mark Gurnell, who's the Section Lead for Department of Medicine and Clinical Lead for Endocrine Services at Cambridge.
Thank you. And I'd like to begin by thanking the organisers for the kind invitation to speak today. And the topic we'll be covering is atypical thyroid function tests. And what I hope to show you is an approach which will allow you to work out whether indeed apparently anomalous results are indeed something or nothing. I will begin with my disclosures. I have nothing relevant to this particular talk. So when I'm thinking about thyroid function test anomalies, I like to consider them under three major categories. Conditions which arise as a consequence of pre-laboratory factors, typically because we as the clinicians have paid insufficient attention to the clinical context. Maybe we haven't thought about the potential variants in TFTs that we might see with age or in the context of pregnancy, or the effects of compounding medications or non-thyroidal illness, or indeed even in patients on thyroxine replacement. There's a whole multitude of issues that we will see shortly that can cause problems with how we determine and measure free thyroid hormone and TSH levels. Or it may be that we're not particularly familiar with some of the rarer genetic or acquired disorders that can produce these unusual results. I think it's always helpful to be able to think about thyroid function test patterns. So these are the typical ones that we're very familiar with: normal thyroid function test, or indeed typically thyrotoxic or hypothyroid patterns of free T4, free T3 and TSH. But it's worth bearing in mind that there are some other patterns. So for example, we may see scenarios in which free T4 and free T3 are normal, but the TSH is actually low or indeed fully suppressed. Or alternatively, the free T4 and free T3 are normal, the TSH is raised. And these are just some examples of the conditions that can produce these patterns. Equally, we may see free T4, free T3 levels are low, but the TSH is not elevated. It's either inappropriately normal or indeed low itself, or the free T4 and free T3 are raised and the TSH is not suppressed, but inappropriately normal or indeed elevated. And again, some potential examples of these are shown here. So what I want to do today is to use the example of raised thyroid hormones and non-suppressed TSH to show you a strategy for sorting out the potential different causes. And as always in clinical medicine, we need to begin with a good review of the clinical context, then consider the potential factors that might be causing laboratory assay interference, and then moving on to consider specific rarer conditions. So if we begin with step one, it's important to revisit the history and the physical examination, determine if there are any interfering illnesses or indeed medications, and also work out whether you think the patient's broadly hypothyroid, euthyroid, or hyperthyroid. And this just helps to serve as a reminder that we do need to bear in mind that there are variations. For example, in age-specific reference ranges probably should be considered here. We can see that TSH does tend to rise even in individuals with no thyroid disease as we age. We also will be very familiar with the context of variations in total and free thyroid hormone levels and indeed TSH during different stages of pregnancy. There are a whole multitude of potential conditions that can produce abnormal thyroid function tests in patients receiving thyroxine therapy. We need to work through these systematically before we often are left trying to determine whether a patient has an issue with adherence to medication or indeed absorption. And then, although many people are aware of potential effects of drugs such as amiodarone on thyroid function, often left appreciated are the effects of drugs such as heparin. This is obviously very commonly used, and it can produce disrupted thyroid function tests by activating endothelial lipoprotein lipase, causing hydrolysis of triglycerides, release of free fatty acids, and displacement of T4 and T3, which really produces a problem, as it were, in the blood tube itself, rather than actually making the patient genuinely hypothyroxinemic. But it can be a problem that, if the sample is not processed quickly and efficiently, can appear to become more of an issue as time passes by. Now, once we've actually considered all those and we've excluded any potential interfering illnesses or medications, etc., we then need to turn our attention to whether there is a problem with the measurement made within the laboratory. And as we'll see with some examples, there are a whole array of different conditions that can cause issues when trying to determine TSH and or free T4 and or free T3 levels. And I'm going to use some illustrated cases to highlight this. This was a patient referred to our service, 72-year-old gentleman by his primary care physician. He'd had stable primary hypothyroidism for many years. His past medical history included hypertension and aortic valve replacement, for which he was on these medications. By the time he was actually referred to our service, he had some features to suggest he was mildly thyrotoxic. And these were the initial TFTs, which had actually triggered the concern from the primary care team. So having had normal thyroid function for many years, the TSH was now raised, albeit with a free T4 towards the upper end of the reference range. And this had precipitated a repeat sample, which had confirmed very similar results. I guess the question is, what should we be thinking about next? Well, in a patient where there is clearly a long history of likely thyroid function test results that you could review, it's worth going back to check these. And you can see that for the most part, on a reasonable standard replacement dose of thyroxine, the patient had normal TSH, but unfortunately, at the time just prior to referral, there was a quite significant change, as you can see, with no change in thyroxine dose, but now the TSH being significantly elevated. In fact, the GP had actually changed the thyroxine dose, gradually up titrating this, but unfortunately this had no effect on the TSH, which if anything was climbing further. But as you can see, the free T4 level was actually also rising. And indeed, by the time the patient actually was referred to our service, they actually had overt features of thyrotoxicosis. So the question is, what should be done next? And in this particular case, this was actually readily resolved by actually sending a single blood sample to 2 different laboratories with 2 different assay platforms. And you can see that the results are very, very dramatically different. In platform 2, we have a completely suppressed TSH with the phrase 3T4, which is very consistent with the symptoms that the patient now had on the increased dose of thyroxine, and very different to those original assay results, which were clearly therefore erroneous. And this patient had interference in the TSH assay, which you will remember is a classic sandwich assay, so a capture antibody with the TSH in the middle and the detection antibody with the signal. And it is possible to get interference in this assay, for example, by the presence of petrophilic or anti-animal immunoglobulin antibodies, which are capable of cross-linking the capture and detection antibodies, even in the absence of TSH, to give a false positive readout. The opposite is also true, where we can actually have antibodies which block the binding of the TSH either to the capture or detection antibody and therefore prevent the sandwich from being formed. Now, indeed, there are other ways in which the TSH assay can also have problems. I'm going to use a slightly different case here to illustrate this. This was a 7-year-old child who was detected to have a markedly elevated TSH on the blood spot post-birth. Now, there's no real concern in the pregnancy or in the labor itself or in the early postnatal period, but you can see the TSH was markedly elevated. And actually, when it was repeated 4 days later, it was even higher, and that caused sufficient consternation that the child was started on thyroxine. But actually, that didn't improve things in so much as not only did the TSH remain elevated, but the free T4 and the free T3 now rose and were associated with a jittery thyrotoxic child. The question is, what's going on here and what should we do next? Well, in the interests of time, I'm just going to show you the thyroid function tests from the mother, which interestingly show a very similar picture to the child at birth with a markedly elevated TSH with normal free thyroid hormone levels. And this is accounted for by transplacental passage of an antibody, which has actually caused macro TSH to form. So this is another form of interference in the assay. On this occasion, the immunoglobulin binds to TSH, but it binds in such a way that it leaves it still able to bind to both capture and detection antibodies, so it has immunological reactivity still, but actually the presence, obviously, of the immunoglobulin bound to the TSH prevents it from being biologically active. So this is indeed a form of assay interference. Again, when we look for problems with the TSH assay, we need to keep in mind presence of potential heterophile or anti-animal immunoglobulins, possibility of macro TSH. Other phenomena have also been reported, such as the presence of paraproteins interfering in the TSH assay. A patient here who on hospital admission had a detectable paraprotein with a markedly elevated TSH level, which actually then disappeared as the paraprotein disappeared. We can also see other rarer reasons why the TSH assay may not be behaving itself. So, for example, here is a very unusual variant of TSH beta subunit in which the mutation renders the TSH immunologically undetectable from a standard assay, even though biologically this is still active. How do we exclude assay interference? The key message is to talk to your laboratory, and they can perform a whole number of different studies, TSH dilution studies, PEG precipitation to remove interfering immunoglobulins, or gel filtration chromatography. I did actually show you how comparison across assays can be helpful, but I would urge on the caution here, because this is not always a reliable way you can have assay interference across multiple assays. Dilution, as I say, is something which can be easily done. Here's a patient with standard hypothyroidism in which their serum is diluted, and we can see that as we dilute and back multiply by that dilution factor, it's pretty consistent. But here's a patient with assay interference. We can see that as the dilution occurs, the weakly formed heterophilic antibodies, the weakly cross-linking heterophilic antibodies here actually dissociate, and therefore the back multiplication does not hold true, and we see a decline in that TSH level. Here is gel filtration chromatography showing that normal TSH comes off, obviously from the column, at a very different place to CSH, which is actually bound to immunoglobulin. I'm going to move on now to a different consideration from an assay perspective. This was a 35-year-old lady who presented with a number of features that suggested hypothyroidism, but actually interestingly had a history of palpitations in the past. But the TSH was markedly elevated, and the free T4, however, was actually also elevated. Thyroid peroxidase antibodies were clearly detectable, whereas TSH receptor antibodies were not. So what should be done next? But in actual fact, when this patient had a blood sample taken and sent to 5 different laboratories running 5 different assay platforms, you can see dramatically different results in the free T4 assays, but a very consistent elevation of the TSH, suggesting the patient really had genuine hypothyroidism. But in the free T4 assays, depending on where you sent the sample, the patient was either thyrotoxic, euthyroid, or hypothyroid. And clearly that cannot be true. So we just need to remind ourselves of the structure of free T4 and free T3 assays. So most laboratories are using a one-step platform whereby a fixed number of binding sites for endogenous T4 or T3 are occupied either by the endogenous T4 and T3 or a competing analog. Of course, we know exactly how many binding sites there are, and we know how much analog we add. So the greater the amount of endogenous hormone, the less the analog is going to bind. Once we have the enhancement solution, we get a fluorescent signal, which is therefore inversely proportional to the amount of endogenous hormone. How can this be perturbed? Well, if anything disturbs this equilibrium, such as altered binding capacity for T3, T4, and therefore T3 or T4 analogs, such as variations in albumin or anti-iodothyronine antibodies, well, they can perturb that equilibrium, so we can end up with a false result. And this will give a false positive result by removing the analog, which would suggest there's more endogenous hormone. One way to get around that is to use a 2-step assay. We introduce a wash step, which essentially keeps the patient's serum and the immunoglobulins therein separate from the analog, which is then back titrated. And in fact, in this particular patient, all the erroneous results for the free T4 were based on 1-step assays, and the correct results came from 2-step assays. So it's worth bearing in mind that the same result in different hands could still be the wrong result. And just for completion, we performed dialysis, which showed that this patient had a genuinely low free T4 level. And this was not due to variation in albumin or familial dysalbuminic hyperthyroxanemia, but instead was due to the presence of anti-iodothyronine antibodies. So the patient had primary autoimmune hypothyroidism with free T4 assay interference. Just to mention FDH, FDH, of course, is a genetic condition with variations in the albumin gene, but it's a genetic condition which produces problems with laboratory assay measurement. So albumin has 4 different binding sites for T4 and or T3. And actually, if we look at one of these binding sites much more closely, we can see there are a number of key residues, arginines, which line the pocket into which the thyroid hormone can bind with their side chains projecting in. Once the thyroxine is in there, it displaces these side chains. But if we mutate one of these side chains, then the pocket can become a little bit more accommodating to T4 or indeed T3, and therefore we increase the capacity for albumin to bind to these sites. And again, we reported a few years ago now how very many of the assays which are commercially available, indeed not just 1-step, but actually rather frustratingly a number of 2-step assays, were subject to interference in families with genetically proven FDH, with varying degrees of interference, even among family members from the same kindreds. And some of the assays were really very prone to give abnormal results, whereas others would sometimes return normal results. So the likelihood of observing interference in the different assay types does depend on the type of interference. 1-step assays are vulnerable to many of the factors that I've described. The 2-step assays generally tend to do a little bit better, but they are still prone to some degree of interference, whereas equilibrium dialysis currently is considered to be the gold standard. Just a word for a moment about biotin. Biotin is both used as a healthcare product, but it's also used in medicine, for example, to treat inborn errors of metabolism, or also, for example, in some patients with multiple sclerosis. However, as well as the other forms of assay interference that I've shown you, such as heterophilic antibodies or macro TSH, it's also worth checking whether the assay that you're using depends on the formation of the streptavidin biotin complex to fix the immunoglobulin to which the analyte is measured, is binding to the bead, for example, in this case. And biotin is a key component of that biotin streptavidin complex. Now, if free biotin in the serum is able to actually occupy these binding sites, then it may actually prevent the formation of this complex between the immunoglobulin and between the streptavidin. And that can therefore produce a TSH result, which appears to be very low. At the same time, biotin actually, in assays of thyroid hormone measurement, can actually interfere with the ability of the assay to detect, for example, analog binding to the bead, and therefore, if there is no apparent analog, the assay will assume or be interpreted as indicating there's high levels of endogenous hormone. So you can actually almost get the perfect storm with biotin, whereby you have raised free T4 levels apparently, but low TSH, mimicking classical primary thyrotoxicosis. And therefore, it's important to know whether your assay is susceptible to this. So once we've excluded laboratory assay interference, then we need to be able to consider specific conditions, either conditions that are associated with raised free T4, conditions which are associated with raised free T3 and with abnormal T4-T3 ratios, or indeed conditions associated with raised free T4 and free T3. Now, in the interest of time, I'm just going to focus on this group at the bottom here, and in particular, trying to distinguish between RTH beta, resistance to thyroid hormone due to mutations in TR beta, and TSH secreting pituitary adenomas, thyrotropinomas, or sometimes known as TSHomas. So I'm going to use a couple of patients just to illustrate how tricky this can be. These patients were referred to our service around about the same time as each other. Both had palpitations, but one patient also had galactorrhea and oligomenorrhea. You can see reasonably comparable thyroid function test results, both with raised free T4 but non-suppressed TSH. But one patient had a raised prolactin and one patient had a normal prolactin. Now, the MRI in the patient with the hyperprolactinemia clearly showed an abnormality with this high signal area non-contrast T1 spin echo MRI, suggesting a structural lesion in the pituitary, whereas the patient with the normal prolactin had, for all intents and purposes, a normal MRI. So if I ask you to declare which patient you think is going to have the thyrotrophic tumor, I suspect it's likely to be case number 4, whilst case number 5 is likely to be considered to be most likely to be RTH beta. However, of course, ironically, the patient who has the structural lesion in the pituitary was subsequently shown genetically to have a mutation in TR beta and also an incidental microprolactinoma, whereas the patient who had an apparently normal MRI was subsequently found to have a thyrotropinoma. So again, it's very important that we don't just make assumptions when we meet these patients, because that could lead to inappropriate investigation and treatment. So just to summarize the differences between TSHomas and RTH beta, but equally also the overlap, the first thing to say is it's very difficult to separate these based on free T4 and free T3 measurements. Both conditions produce elevated results, but as you can see, there is considerable overlap. Here we're showing results from patients with proven TSHomas denoted by the red circles and patients with genetically proven RTH beta shown by the green triangles. Equally, it can be extremely difficult to separate the two conditions based on TSH levels. TSHomas may have a tendency to occasionally have higher TSH levels, but in many patients, these TSH values fall within the appropriate reference range or only slightly elevated, as can be seen in patients with RTH beta. Sex hormone binding globulin is a liver-expressed protein which is sensitive to thyroid hormones, and for a long time it was considered that it was going to be raised in patients with TSHoma and normal in patients with RTH beta, because the TR beta isoform, as well as being expressed in the hypothalamus and pituitary, is also expressed in the liver. But we have been able to show that, unfortunately, there is considerable overlap in SHBG levels between patients with RTH beta and TSHomas. And actually, it's interesting that many of the patients with micro TSHomas seem to often have SHBG levels which are within the normal range. And this holds true whether we're looking at premenopausal, postmenopausal, or in females or indeed males. One of the investigations which does seem to separate out between the two entities quite nicely is the serum TSH response to intravenous TRH. And you can see in these two cohorts of patients with proven thyrotrophic adenomas that the TSH fold rise is blunted, and notice the fold rise we're talking about here, with virtually all patients, with just one exception, not increasing above a 4-fold rise. Whereas with RTH beta, we tend to see preserved, or indeed in some patients, exaggerated fold rises in TSH after injection of TRH. And again, you can see an almost complete separation, not quite, a little bit of overlap just from a couple of patients here. But this seems to be a very good test at separating between the two. Similarly, the response to first-generation somatostatin receptor ligand therapy has also long been recognized as a potential route to separating these entities. So Paolo Beck-Pecos and colleagues many years ago showed that patients with resistance to thyroid hormone often showed very little in the way of change in either TSH free T3 or free T4 following depot injections given every 28 days, whereas patients with TSH-OMA showed a quite nice drop, in particular in free T3 levels, often achieving a euthyroid state, as it were, with improvements in free T4 and also some, but not so dramatic, change in TSH itself. And indeed, Philippe Chanson and colleagues have shown that this is a very effective form of treatment for TSH-OMAs, and indeed some patients with TSH-recruiting pituitary tumours can actually develop a form of central hypothyroidism, almost requiring a block and replacement strategy on the basis that the normal thyrotropes are still asleep and the somatostatin receptor ligand is nicely suppressing the tumoral thyrotropes. What about back to our patient who had suspected TSH-OMA with no genetic cause identified for RTH beta, but with an apparently normal MRI? Well, again, there are numerous approaches here to now being able to try to identify where these lesions are. And one of those is to use functional molecular imaging. We've spent a lot of time, for example, working with 11-carbon-methionine as a PET tracer. This is taken up by both normal pituitary tissue, but also quite nicely by thyrotropinomas. And here we can see in this patient's MRI, it's really difficult to discern the presence of a tumor. It can show you ultimately that this is actually where the tumor is, but I think it'd be difficult to call this when you're looking at the MRI on its own. But interestingly, on the first PET scan at baseline, there is tracer uptake, which is skewed towards the left-hand side. So this is a combination of some normal gland uptake, but also uptake by the tumor. Then after the patient has been treated with 3 months of somatostatin receptor ligand, not only does that normalize the thyroid function test, but in this instance, it also resulted in a change in the distribution of uptake of the methionine, which now became more central. And Dan Gillett, a colleague of mine working in nuclear medicine, was able to perform what's known as subtraction imaging, which is to delete this PET signal post-somatostatin receptor ligand from the original pre-somatostatin receptor ligand PET scan and produce essentially a subtraction or difference image, which beautifully localizes where this tumor was subsequently found to be at surgery. And this patient then went into complete biochemical remission. So this is an added entity now which can be put into the algorithm to help us to separate out RTH beta and TSH-OMA. So going right back to where we started in this talk, it's always important to make sure that before we jump the gun, we've excluded any interference in free T4 and free T3 assays, indeed the TSH assay, and we've also thought about the potential confounding effects of drug therapy or intercurrent illness. But then once we've worked our way through and we're trying to distinguish between RTH beta and TSH-OMA, there are a whole combination of different tests that we might need to use. Obviously, if there are affected family members, or of course we get a positive gene screen when we're looking at RTH beta, but it may be that we need to combine a number of tests, both biochemical markers, dynamic testing, such as the TSH response to TRH, or indeed the T3 suppression test, or, as I've just shown you, hopefully combinations of treatment, for example, with first-generation somatostatin receptor ligands, and, if needed, molecular imaging to complement standard anatomical imaging to help separate these. So really, to summarize, important that we review the clinical context. Once we're happy that actually we know what we're dealing with in terms of the clinical scenario, Then we need to talk to the laboratory and make sure that we're not looking at any form of laboratory assay interference. And thereafter, we need to think about specific conditions, which we may not be that familiar with and which we may need to speak to other colleagues about in order to help us to distinguish between conditions which are often only seen relatively rarely in our services. So I need to thank you for your attention, and I need to acknowledge all of my colleagues who contribute to all of this work, in particular, my long-term mentor, Chris Chatterjee, but also colleagues in biochemistry, and also Carla Moran, who's been working with us for many years and is now back working in Dublin. Obviously, the funders who support us, but most of all to the referring clinicians and patients, without whom we would not be able to do this work. And I'll leave you with some key references, which I think you may find helpful to complement this talk. Thank you very much for your attention.
Thank you very much indeed, Mark. Very clear and informative as ever. I'm just going to look at the chat to see what questions we've been receiving. So any use of TSH alpha measurements to distinguish between the two?
Yeah, thank you. It's a good question. We have yet to publish this, but we do have quite a sizable series that is going to show, I'm afraid, that probably the alpha subunit really only comes up positive clearly in patients with macroadenomas, where usually the diagnosis is already beyond doubt, Amir. Unfortunately, it doesn't really seem to distinguish between microadenomas and RTA. I'm afraid, probably just simply representing the volume of TSH production and the disproportionate production of alpha subunits. So regrettably, probably not very helpful, I'm afraid.
Thank you. What about subcutaneous octreotide short-acting injection? Do you have any data on that? Because you've shown us the depot response.
Yeah, it's a good question again. So we have done quite a lot of comparisons now of patients who respond to the depot and those small number of TSH tremors which don't. And unfortunately, in our hands, using a standard 3-hour octreotide suppression test, we have not seen a good correlation in terms of the response to the short-acting versus the depot. It is interesting, however, that there was a paper published about 18 months ago that suggested if you actually followed those thyroid function tests out longer than the conventional 3 to 6 hour version of the octreotide suppression test, it might be able to predict the response to depot. We don't have any experience of that. We've tended to do just a test that literally lasts half a day. And in our hands, that particular version hasn't proved particularly helpful.
Thank you. And could you briefly comment on T3 suppression test?
Yeah, it's a really good test. So again, our very good colleagues and friends, Paolo Beck-Pecoz and Luca Pisani, have done huge amounts of work on this in Milan. And actually, the argument is that it may well be the most sensitive indicator of a small volume of residual thyroid for example, following surgery. One of the reasons we have not embraced it as much is I think we've uncovered in our cohort that there's actually higher rates of cardiovascular disease and tendencies to atrial fibrillation than has perhaps been suspected previously. And of course, if you're going to do a T3 suppression test, you're talking about giving really decent doses. We're talking about anywhere between 100 to 200 micrograms of T3 a day for minimum 5, and typically the classical test up to sort of 10 days. And that's not an insignificant risk, therefore. So the reason we went for combination TRH and somatostatin receptor ligand as probably our best tests prior to imaging was because they don't present the same risks as occurs with a subgroup of patients with T3.
Thank you. And I think Dr. Rahman is thinking about the patient that I was thinking about when you were delivering the talk. We were discussing yesterday at Imperial, a patient with a TSH macroadenoma who was pregnant, 21 weeks, I think. So surgery or somatostatin receptor analogs.
Yeah, so again, this is an area where actually I'd strongly encourage you guys to put this case forward for publication once you get to the end. It's a mixed bag when you review the available literature. There are those who feel that actually somatostatin receptor ligands in pregnancy may have their risks, and of course they could, and there have been concerns about intrauterine growth retardation, but you have to remember that it's confounded by how well the thyrotoxicosis is controlled. We have treated people with somatostatin receptor ligands in pregnancy and have not had any adverse consequences of that. So I think actually the balance comes down to what are you trying to achieve, and in particular, are you looking at a visual compromise, which might mean that you have to think about second trimester intervention, or are you actually concerned principally about the thyrotoxicosis? And again, of course, you could try all sorts of strategies, anti-thyroid drugs versus somatostatin receptor ligand. Problem with the anti-thyroid drug is that the TSH may get bigger. The pituitary is already getting bigger. So I think here in these situations, these patients have to be handled in specialist centres, very clear discussions about the unknowns and the pros and cons here, and a willingness to change strategy and direction if it's not going in the right way. And the patient would need to know, if staying on somatostatin receptor ligand, that there is data out there from acromegaly, of course, as well as from the rarer TSHomas, which is largely reassuring, but it is an unknown and it's not licensed.
Thank you. And then the final question, we were talking about the risk of apoplexy. Do you have any data on these?
So we have done with somatostatin receptor ligand or TRH testing, Amir, or both. I can answer both. TRH testing has obviously been putatively reported to potentially cause apoplexy in TSHomas, and in fact some of the data goes back to triple testing of patients in days and things that we don't do any longer, I think. We've never, and I now say that by being very careful that I'm about to cause it in our group, but we've never seen an apoplexy in response to TRH, nor have we seen one so far in response to somatostatin receptor ligand, unlike as you do with cabergoline, for example, with prolactinomas. So I think that there are cases described, but I think I always mention it to patients, but I'm pretty cautious about overplaying that.
Thank you so much. Really grateful for you to join us, Mark. I know it's been difficult to join, but really grateful for your input into the questions. I'm afraid in the interest of time, we need to move to our third speaker, Professor Fausto Palazzo, who is the Senior Endocrine Surgeon at Imperial and the clinical lead of the UK's largest department of thyroid and endocrine surgery, I believe. Fausto, nice to have you back.
Well, thank you very much. I feel after the last two talks, I'm going to lower the tone slightly, but I guess that's the purpose of a surgical talk to endocrinologists, to give you a bit of light relief from the science. And so I suppose you could say, if we were at medical school, you'd say, okay, now put down your pens and just relax. Because we're going to talk about the evolution of thyroid surgery. Now, evolution is a gradual process in which something changes into a different, more complex, and one presumes a better form. And this evolution doesn't necessarily happen in a linear fashion. So I'm going to talk to you today in two parts. One is going to be a bit of the history of thyroid surgery. And the second part is going to be how thyroid surgery has changed in modern times. And I'm sure there'll be some questions about this latter part in particular. So early thyroid surgery was non-anatomical, and its origins lays with the writings of Abu al-Qasim, who wrote an authoritative Arabic medical tome called Kitab al-Tasrif. Now, he published at the end of the first millennium a case of somebody who had a part of the thyroid gland removed and they survived. So you could see even 1,000 years ago there was publication bias. The European first documentation of thyroid surgery goes back to the medical school in Salerno, which is the world's first medical school. It no longer exists. And then in subsequent centuries, there were isolated reports of thyroid surgery. But this, it should be clear, was not surgery as you and I know it. It was brutal surgery based on tying a bootlace or a seton across a thyroid mass. And in the bottom right-hand corner, you'll see that in modern-day London, there are still the sort of goiters they had to deal with then. But of course, we remove these rather than just ligate them. Things changed thanks to the anatomical drawings. And the anatomical drawings, first and foremost, were those of Leonardo da Vinci. And Leonardo da Vinci drew the thyroid gland and appears to have had a vague fascination with the gland. Now, he died in 1519, and these drawings were discovered 250 years later and immediately snapped up by the royal family, and are now to be found in the Windsor collection. And they are absolutely fascinating if you ever have the opportunity to look at them. Vesalius was an anatomist in Padova in northeast of Italy, and he not only drew the thyroid gland anatomically, but also described it very clearly. And then finally, Thomas Wharton is considered responsible for the naming of the thyroid gland. And it's thanks to this anatomy that it was possible to consider anatomical surgery. A couple more words about Leonardo da Vinci and the thyroid. On the left, you can see the Madonna of the Carnation, because you can see that she's holding a carnation. She's also known Madonna with the rose, but also known commonly as the Madonna with the goiter, because of her goiter. And it was, while looking this up, I found this wonderful paper where it was hypothesized that the Mona Lisa, or Lisa Gherardini, who is the person that's been painted, was actually hypothyroid. I thought that this was an example of an endocrinologist with perhaps a little bit too much time on their hands. So anatomical thyroid surgery started at the end of the 18th century, and the first thyroidectomy, anatomical thyroidectomy, was performed by Pierre de Sceaux in 1791. And I think that his first operation can only be described as beginner's luck, because the patient survived. Subsequent operations ended with death. The first total thyroidectomy was equally with a bad outcome by Guillaume Dupuytren, who's more famous for the Dupuytren's contracture of the hand, and that patient died of shock. By 1850, so a long time passed, and there are only 14 reports of thyroidectomies where the patient actually survived. Now, it will come as no surprise, therefore, that thyroid surgery was condemned. It was condemned in Germany. It was banned by the French Academy of Medicine, which is like the Royal College of Physicians and Surgeons. And then finally, famously, Samuel Gross, who was a professor of surgery in Pennsylvania at Jefferson, made this statement in his textbook. He asked a rhetorical question, then went on to answer it. He asked whether it was possible to remove the thyroid gland with a reasonable hope of the patient surviving, and he went on to say the answer has to be no, and finally that no honest or sensible surgeon would engage in this type of butchery. This is the view of the time. But of course, we have to understand that the problems of thyroid surgery and lots of other surgery were related to the circumstances in which they had to work. You have to remember that there was no general anaesthetic until the mid-19th century, when ether arrived. And so the operations had to be done very fast. And then you had the issue of sepsis, and Lister, who worked in Glasgow, used phenol, which was, I think, then known as carbolic acid, to sterilize surgical instruments, the skin, sutures, and so on. And then that was followed by Bergman, who we used the steam sterilization of instruments. And these things are very important, because if you survived the operation, if you had antisepsis, then there's a chance that you might actually survive and not have an infection. And the final change in that allowed the implementation of more what we might consider modern surgery is the arrival of instruments like hemostats in particular, which allowed us to do operations without a catastrophic bleeding. But the father of thyroid surgery is Theodore Cocker. Now, there's a chap that preceded him called Theodore Billroth, and both of these surgeons worked in Mittel Europe, in other words, southern Germany, Austria. And the reason is simple, because in the mountainous parts of Central Europe, multinodular goiters were extremely common because of iodine deficiency. And he described thyroid surgery, and he was a thinking surgeon, because what he noticed is that when he did a total thyroidectomy and the patient survived, the patients became unwell, developing something that he described as cachexia strumipriva, which of course is actually hypothyroidism. And having noted this, he stopped doing total thyroidectomies. And by 1907, he published a series of 3,000 thyroidectomies for non-toxic goiter, and it's important to underline that, with a mortality which was considered extraordinary at 0.3%, which is actually respectable even 100 years later. Now, why did I underline the issue about it not being a toxic goiters? Because he was a smart guy, because he avoided operating on toxic patients, thyrotoxic patients, but where in the patients he did operate on, he had a mortality of about 1 in 20. Now, at that time, Graves' disease was only described in about 1835. Of course, Graves' disease was not called Graves' disease in Vienna or in Germany. It was called von Bestow's disease. And that's why in mainland Europe, it's still not called Graves' disease, it's called von Bestow's disease. And Kocher avoided operating on these patients, and his prestige was enormous. And by 1909, he'd received the Nobel Prize for Thyroid Physiology, Pathology and Surgery. At this stage, I have to say a few things about the surgery for thyrotoxicosis, especially after the talk by Mark Vanderpump. Now, this is an example of where multidisciplinary practice is really helpful. And of course, 100 years ago, it didn't exist. Now, physicians felt that thyrotoxicosis was basically, it's a medical disease. And they felt that some toxic goiters seem to just spontaneously get better. So there's no point in operating on them. So the only patients that were ever referred by the physician for surgery were when they were completely out of control. In other words, they were moribund, and therefore the patients went on to have surgery and the outcomes were appalling. And this started a vicious circle because, of course, the outcomes were so bad that the physician said, well, we're not going to send the patient for surgery because they all die. And Kocher, who was hugely influential at that time, stated that you should never operate on a thyrotoxic patient. In other words, when the pulse was fast and irregular. Of course, what else were you supposed to do? So he had a huge influence on surgery for thyrotoxicosis, and it's in this context that one of my surgical heroes emerged, and that is Thomas Peel Dunhill. Thomas Peel Dunhill is slightly the forgotten man of historical thyroid surgery. He was British in origin, but he was born in Australia, and he qualified as a pharmacist. He came from a humble background, and he financed his medical school after pharmacy by doing pharmacy, working as a chemist, in other words. And he was an outstanding student. And he had a particular interest in thyrotoxicosis, or exophthalmic toxic goiter, as you might call it. Of course, it's Bestow's disease. I should point out at this point, actually, given the audience, that the first description of an exophthalmic goiter is actually from the Persian physician Syed Ismail al-Jurani, who wrote something called the Thesaurus of Shah of Qazwan. Anyway, I don't want to take too much of a tangent, but it's obviously an interest of mine. But what Dunhill noticed, another thinking surgeon, is that basically medical treatment for Graves didn't work, and the treatment at the time was very haphazard. It consisted in ice pack and bed rest, and giving people milk of thyroidectomized goats, or a variety of drugs, or even using electric currents. And these patients basically died. They died of cardiorespiratory failure, diarrhea and vomiting, and they were usually or often became blind from corneal ulceration, which of course will be relevant to the talk that's about to follow mine. And the other peculiarity is that the one thing that might work, in other words, the John Basedow effect of iodine, was not used. And the reason was because Kocher was of the view that this should not be used. And it was only when Kocher's authority started to wane in the 1920s that Plummer reintroduced the use of iodine. So what did Dunhill do? He realized that medical treatment didn't work, and he thought that in some patients surgery might be of use, and he started treating thyrotoxics, and led to had an influential effect in subsequent years. So this is the operation note on Mary Lynch, one of Thomas Peel Dunhill's early patients. So this is a 36-year-old Irish servant, and she was in a terrible condition, and she would take any risk rather than continue as she was. Now, I love this operation note, because if you, first of all, you note that doctors wrote badly even then, and you can see the patient's name, Mary Lynch, and you can see exophthalmic goiter and the date, 25th of the 7th, 1917. And the description, you can see that who did the operation. And this was not written by Thomas Peel Dunhill. The operation was done by him, and that's documented. But it was signed off by his houseman in the good old days when the houseman wrote the operation note. And this is Dr. A.H. Harker. And it took me ages to work out what RD meant. And what it signifies is relieved and discharged. So another bit of interesting medical history. So this patient, Mary Lynch, was successfully treated and went back to working in a Victorian hotel. And what he noticed, what Dunhill noticed as far as the treatment of thyrotoxic or toxic goiter, was that he would stage the operation, in other words, do a hemithyroidectomy, then do a total thyroidectomy, until he got the confidence to be able to do the operation in one sitting. And he went on to present this data in tours in the United States and the UK. And he was due to give a talk at the Royal Society of Medicine in February of 2012, but was unable to do so because he had to go back at that point to Australia. He later returned to St Bartholomew's, where he became a surgeon, the leading surgeon there. So his talk had to be given by James Berry. Now, James Berry, I suppose I've got something in common with him in that he demonstrated anatomy at St Bartholomew's like me, but he was a surgeon at the Royal Free Hospital, and he was a leading light in British or English thyroid surgery. In fact, he's left his name on Berry's ligament, the eponymous ligament that attaches the thyroid to the larynx. And James Berry presented the work of Thomas Peel Dunhill at that meeting, and he damned Dunhill with faint praise, saying that it was very difficult to reconcile the optimistic view of Dr. Dunhill with the results obtained in the UK, which was a high mortality. And then he calls into question whether any of Dunhill's patients actually had Graves' disease. So what's the take home here? Don't let your colleagues present your scientific work. So that's the history of thyroid surgery up until the 1920s, more or less. And really nothing happened in surgery, thyroid surgery, well into the 1970s. Of course, there were a couple of world wars that had to be dealt with and other issues. But nevertheless, there were very few developments. And from the 1970s onwards, we have had a new phase of evolution, and the evolution has regarded 4 different issues. One has been how the decision making is made in thyroid surgery, the techniques that we use, the technology that's been introduced, and another very important thing in thyroid surgery in recent years, which is the issue of data collection. So now, this is a physician audience, so many of you may feel that surgeons shouldn't be trusted with any sort of medical decision making. And you might be right, because multidisciplinary team meetings have added a great deal to the decision making, not only in thyroid malignancy, but also in benign thyroid disease. In other words, having open discussion, open forum discussion on the decision making has definitely been of benefit to the patients, because with other clinicians available, it's possible to contextualize the patient better rather than just consider them an object to operate on. And we consider the patient's life expectancy and comorbidities much better than we did before. And Therefore, we are unlikely to do unnecessary surgery, and the extent of surgery is better chosen. But there have been other byproducts of MDTs, and they are the scrutiny of open forum. In other words, we're not just working in silos. Now, our physician colleagues have an interest in and know what we do. And this is also the other thing that MDTs have done, is it's led to a degree of specialization, because the attendance of an MDT is a declaration of interest in a specialty, and the time being limited, one can only really attend one or two of these things. So what's happened to surgical technique over the last 40 to 50 years? Well, the approach to the operation, in the first instance, we have moved away from big incisions. We've moved far more towards small incisions, or even minimally invasive surgery, as it's sometimes called. In the past, we adopted what's called a lateral dissection in order to avoid the recurrent laryngeal nerve. But of course, by doing a lateral dissection, we devascularize the parathyroid glands. And now we perform a capsular dissection, so we're right on the thyroid gland, and we identify routinely the recurrent laryngeal nerve. And you'll see afterwards we talk about nerve monitoring. We use nerve monitoring too. The external branch of the superior laryngeal nerve is the neglected nerve. It's very important if you're a professional speaker or singer in particular, because it affects your ability to throw your voice and to reach high pitches. Now, we now routinely seek, identify and preserve the external branch, again with the use of nerve monitoring, which I'll discuss afterwards. The completeness of surgery in the past was you just removed what was in front of you, but now we actually seek out accessory thyroid tissue or embryological remnants like thyroid rests. And finally, the parathyroid glands are for once actually given some respect, and we do everything to preserve their function, and we auto transplant them when we can't. But in the past, the parathyroid glands were not given much importance. Now, we've been helped a great deal by technology in the last 40 or so years, and in particular the last 2 decades, we've seen the arrival of advanced bipolar technology and the harmonic scalpel, which are both hemostatic devices. Now, when these devices arrive, industry always has a great interest in ascribing to these instruments miraculously improved outcomes. It seems to always happen. But the truth is that these hemostatic devices definitely are of benefit, but they're of benefit in a way which often is not easy to quantify. So the first thing is, yes, they shorten the operating time, but the great advantage of shortening the operating time is not only because you can plan theatre time better and therefore be more efficient, but also a shorter operation means that the surgeons don't get so tired, and tired surgeons are more likely to make mistakes. So these hemostatic devices are incredibly good. And on the days when for some reason we don't have it, it's miserable because the operation takes longer and we get tired at the end of a long day. Nerve monitoring is another major advance, again in the last decade or 15 years in particular, as it's become more sophisticated. And again, the great driver has been to try to demonstrate that the nerve monitoring improves outcome, and we'll discuss one of the landmark studies on that in a few moments. In addition to nerve monitoring and hemostatic devices, we've got the last issue, the last bastion of thyroid surgery is preservation of the parathyroids, which is still an unmanaged problem. The rate of hypoparathyroidism is much higher than we think, and autofluorescence has been used to address this issue. Now, we were one of the first departments to publish our data on autofluorescence, and we did not find that it improved outcome as much as we had hoped or expected, and therefore we don't use it routinely. We may use it as a part of a national study, and we've been a part of a randomized controlled trial in the UK, which is randomized to the use or non-use of autofluorescence, and the study has been suspended because of the lack of difference, but that data is yet to be published. The fourth thing that's happened that's been very important in thyroid surgery is the fact that we have moved away from centers of excellence declaring fantastic results, which everybody else is envious of, and then quotes but cannot match. And we've moved towards anonymized national databases, which give us some real data. So we now know how many people actually do die. About 14 people in every 1,000 dies after a thyroidectomy. And this is something which you see in the national databases and the European wild databases. The hemorrhage rate in specialist centres like ours is certainly less than 0.5%. But if you look at national databases from Sweden and mainland Europe, it is 4 or 5 times that. And just to give you an example of what happens when politicians get involved in determining how disease is managed, in Denmark, some 15 or more years ago, they decided that head and neck clinics were going to be used to investigate and treat all thyroid lumps. And as a consequence, all the thyroid surgery was done, whether they liked it or not, by ear, nose and throat surgeons, not specialist ear, nose and throat surgeons, but just ear, nose and throat surgeons, head and neck surgeons. And the post-operative return to theatre rate for bleeding was more than 1 in 20. So that just gives you an idea. So we're talking about many times more than a specialist centre. But what about the vocal cord palsy rate? Now, the thing about the vocal cord palsy is we know that in specialist centres it's uncommon. But what about the national data? Well, the problem is it depends on whether you look for it. So we know the range is between 0.3 and 7%, even in the registries to an extent, if you look at individual surgeons. The problem is the ones who don't do a laryngoscopy after surgery, incredibly, are the ones that have the lowest rate. But it's obvious because they haven't looked for it. Whereas if you look for it, you are going to find it far more frequently. And it's now mandatory in the UK, certainly in many other countries, to do a pre and post-operative laryngoscopy so that you can tell your patients before the operation what your personal data is. And this isn't just surgical dishonesty, by the way. It's sometimes the surgeon's unaware, especially if they haven't used a nerve monitor, that the nerve is not conducting. And you can have patients who initially don't even demonstrate a significant change in voice. And there is unquestionably an issue about publication bias, in that no surgeon or no physician wants to publish data which puts them in a negative light. So when the nerve monitor came out to try to address this issue of nerve injury, Henning Drallo was a leading surgeon of his day from Germany, and Halle in Germany, wanted to demonstrate that the nerve monitor improved outcome. And a cynic would say he was very heavily supported by the industry, who wanted to prove this for their own commercial benefit. So he looked at 16,500 thyroidectomies in Germany. It's 29,000 nerves at risk. So every thyroidectomy has 2 nerves at risk, left and right, if it's a total thyroidectomy, of course. And what he wanted to demonstrate was that if you used a nerve monitor, your rate of nerve palsy was lower. But instead, what he demonstrated was that if you were an experienced surgeon, you had lower rates, whether you used a nerve monitor or didn't use the nerve monitor. And this was a groundbreaking piece of work. And this is the graph from his landmark paper that shows that as you increase your activity annually, your rate of permanent vocal cord palsy goes down. So if you look here, this is at 100, we're dealing with effectively 50 total thyroidectomies. So if you do 50 thyroidectomies a year, your permanent nerve injury rate is going to be less than 1%. And this paper was then reproduced in bigger anonymized data from other centers all over the world. And I'll just show you one which is a significant paper from the UK, published in 2021, of almost 23,000 thyroidectomies. And again, what did they find? The high volume practices had the fewest post-operative complications, shortest length of stay, less readmissions, less hypoparathyroidism, etc., etc. So there's clearly a correlation between volume and outcome, but the problem is defining low volume, and that's where the controversies kick off. And exactly the same work has been done at a European level, European Society of Endocrine Surgeons, looking at all the worldwide data. And it's just a recurrent theme that there's a volume outcome correlation. And as a consequence, all the guidelines say that surgery should be done by an experienced surgeon. The only problem is that defining that surgeon is been left in the hands of the surgeons. So if you ask a surgeon, are you a high volume surgeon and you're experienced, everyone's going to say yes, especially if they need to do some work. And this is where the value of MDTs and physicians come in, because when the physicians get involved in a decision-making process, which includes where the surgeons are operated on, the outcomes tend to be better. So in summary, the history of thyroid surgery started in one tragedy after another, where the patients essentially were subjected to almost ritualistic butchery. And then it basically has evolved in two phases. MDTs have improved decision-making and therefore improved outcome, and technology may improve the results, but it's without doubt that it's the surgical technique, training, experience, and practice volume that is the single greatest predictor of outcome in thyroid surgery. I hope this has been of interest to you, and I'm very happy to take questions. Thank you.
Thank you ever so much. Really interesting and informative, Fausto, as you can see from the applause, electronic applause at the bottom of the slide. So, yes, there's a lot of excitement, as you can see, which is fantastic. I think I'm going to suggest, if that's okay, we'll move on to the next speaker in the interest of time. And we hope to see you again in future masterclasses. Really grateful for your talk.
Thank you.
So, great. Now, as you noticed, we didn't have a break because the feedback from the previous masterclasses was that you wanted to continue with the talks, and that's what we've done. But please do feedback anything else we can do to improve. It's my pleasure to introduce Miss Vickie Lee, who's consultant ophthalmic and oculoplastic surgeon at Imperial. She's a leading specialist in thyroid eye disease. She's actually the British Oculoplastic Surgery Society's national lead for thyroid eye disease, and has authored the national guidelines for thyroid eye disease and leads the multidisciplinary thyroid eye disease services across 3 London NHS hospitals for thyroid eye disease that are actually internationally recognised. She's going to talk to us about new frontiers in thyroid eye disease. Over to you.
Thank you very much, Amir. Hi. And these are my disclosures, and thank you for giving me the opportunity to share some very exciting new developments in this field. Thyroid eye disease, which I shall refer to as TED throughout this talk, is a miserable condition for our patients. As you can see, it imposes a heavy socio-economic and psychological burden on all our patients who have this condition, and incurs huge direct and indirect costs to both the individual and society. In this even bleak study from Denmark, it was found that TED patients are 3 times at risk of dying from suicide compared to patients without any hypothyroidism, and twice as likely in patients who have Graves' disease without the eye disease. The Amsterdam Declaration in 2009, almost 15 years ago, recognizes the lived experience of our patients and the accessibility of effective, timely treatments. And the main aim was to try to improve outcomes. So one beacon has been UGOGO, which is a European group on Graves' orbitopathy. These are 22 centers with MPT services treating thyroid eye disease, and I'm proud to be working in the London center. And UGOGO has been a beacon in featuring new developments and evolution of treatments, including the use of selenium, the various guidelines for thyroid eye treatment, as well as developing the gold core, which I will talk about later. So the response in the UK has to be informed TMED, which is to try to improve outcomes in thyroid eye disease by correct diagnosis, screening, alerting patients, preventing TED, and trying to get them access to a thyroid eye clinic. And we came out a couple of years ago with guidelines for this condition. Sorry, my slides seem to have suddenly a life of their own, seem to be advancing by themselves. So sorry about this toing and froing. But the guidelines for the UK were launched in 2019. So here I'm going to talk about the new frontiers in the disease, and we're living in very exciting times. So the main 4 areas I'm going to address is to try to improve the diagnosis and decrease the risk of TED, improving assessment consistency, talking about advances in pathophysiology, and looking at new therapeutics which have been developed. So the first one deals with screening for TED and the use of radioiodine. So I'm going to misquote the famous Jane Austen here, that thyroid eye disease is the leading cause of proptosis and orbital cause of double vision, but it is not the only cause. So it's very important to bear in mind other reasons. Also, about half of the patients will have thyroid, of Graves' patients will have thyroid eye disease. But so therefore, it's important that all endocrinologists alert their patients and be alert to the possibility of TED. The first screening tool in use is the Vancouver orbitopathy rule, in which a yes to questions 1 and 2, and another yes to 3, 4, and 5 merits a referral to a thyroid eye specialist. The second screening tool was described by Ugogo and takes into account 4 aspects to produce a composite score, which are the clinical activity score, the thyroid antibody titer, the duration of hypothyroidism, and current smoking. And a score of 6 or less makes thyroid eye disease very unlikely. So moving on to radioiodine, NICE recommends it as first line. We know since Bartolena's publication in the late 90s that it can precipitate or exacerbate the onset of thyroid eye disease. We tend to have a full-on discussion of all our patients about definitive treatments. We tend to recommend avoiding RAI in patients who had moderate to severe disease needing immunosuppression. And we give steroid cover for patients who are at risk using the Prodigo score. And we found that in the course of the last 7 years, we had a very low percentage of TED exacerbation and progression. So I think use with care. The next step I'm going to move on to is to improve the assessment of thyroid eye disease. And the 2 aspects we need to think about is severity and activity of disease. So one of the majorly used endpoints in all trials is the clinical activity score, and many of you may be familiar. It was described by Moritz in the late 1980s. It's become a common language between endocrinology and ophthalmology. It's a binary score, so it's either present or absent, and it measures for inflammation, pain, swelling, and redness at first visit. But the loss of function, such as worsening eye movements, decrease in vision, or worsening proptosis, is only measured at follow-up assessment. It's also useful to bear in mind that it was developed in the Netherlands, so its reliability in patients of other ethnicities rather than Caucasian can be sometimes less reliable. So the second endpoint that's widely used is exophthalmometry. This is the measurement of the displacement of the eye forwards, and can be used by the exophthalmometer in the clinical setting, as you can see here. However, the reliability of measurements very much depends on the technique and training of the measurer. It can also vary from exophthalmometer to exophthalmometer. Again, it's important to bear in mind that there are ethnic variations about the upper limits of what is normal levels of proptosis. And also, it only measures the horizontal displacement of the eyeballs. And we're all very familiar that the thyroid eye disease can displace the globe also vertically, and this is not captured in exophthalmometry. So how can we improve the assessment? Well, we have to bear in mind what variabilities there are. There can be variability between observers, between the same observer from day to day, between the patients even from day to day, and of course between different devices. So I suggest and recommend that you use several different assessments to build a full picture. Many of us are familiar with visual fields. They can diagnose and monitor treatment and also detect subtle sight-threatening disease. This is one of my patients who had dysthyroid optic neuropathy. They had normal vision, normal color vision, but visual field defects which improved after immunosuppression. It's also important to remember that about a quarter of the Ugogo thyroid optic neuropathy study, they had a low CAS and their vision was fairly normal. And so visual fields were the only things which are picking up the fact that these patients had sight-threatening disease. The second measurement is that we know that thyroid eye disease can affect eye movements and enlarge the extraocular muscles. So using objective scores, testing for double vision, as well as the movement of each single muscle, can help us monitor the effect of treatment and also to detect progression of the disease. The third example that we should use is using a quality of life measurements. This helps to address the gulf between our patients' lived experience and often the clinician's impression of the severity of their disease. A goal call, a 16-question questionnaire developed by Ugogo, is the only one that fulfills all the criteria for validity, consistency, and the ability to detect changes. And a change of 6 points or more on the visual or appearance subscale is significant, and it is fundamentally important in deciding whether to use treatments for patients and justifying treatment in what is clinically mild disease. The fourth one is the use of MRI. TED is a soft tissue disease, so MRI is the only logical radiological investigation to use. Clinical activity score biases towards the anterior orbit, whereas in the posterior orbit, we can derive a radiologically activity score to look at what is happening in the fat and the extraocular muscles. We have been working towards actually quantifying inflammation in the orbit by using something called apparent diffusion coefficient, which looks at the movement of water molecules. This is increased in inflammation, and we have found that actually by measuring the apparent diffusion coefficient, this correlates well with CAS scores as well as severity of disease. And also we're working towards developing cutoff values for both active against inactive thyroid eye disease and those with or without sight-threatening disease. So in summary, I would recommend using a composite assessment to build a full picture of your thyroid eye patients and arriving at a composite score using many modalities, including clinical assessment, photography, quality of life, radiology, and of course, not forgetting the thyroid. So next step I'm going to move on to is the pathophysiology and therapeutics and the new frontiers here. So what should a successful TED treatment be? It should restore visual function, both in terms of visual loss and double vision. It should reverse disfigurement, mainly the proptosis, and also have a good safety profile. So the conventional treatment paradigm has been described by Ugogo. We're currently on the third iteration of the guidelines. And this is deemed that for steroid treatment, only about a third are suitable for immunosuppression. And it's important to remember it does not reverse the disfigurement caused by the disease. Disfigurement is only addressed much further down the line with a rehabilitative surgical sequence, often many years later when the thyroid and eye disease are quiescent, and can take a form of orbital decompression, followed by extraocular muscle surgery for intractable double vision, followed by eyelid surgery to try to restore our patients to a more normal appearance. So the Ugogo guidelines have changed little in the last 3 iterations. Mycophenolate was added in 2021 and for the sight-threatening protocol, the previous one referred to the moderate to severe disease, is not changed since the guidelines in 2008. So if you look at the evidence base of each, steroids. Intravenous methylprednisolone has a superior response to oral steroids. It's more effective than placebo. However, it needs 4.5 to 7.5 grams to be more effective. We're all familiar with the short-term and long-term toxicity. However, it doesn't really reduce proptosis, less than 1 millimeter found in this systemic analysis. And not very good for double vision either, about 50% response, look at several studies. So the rationale for adding mycophenolate was on the basis of the Mingo trial that found that on post hoc analysis, mycophenolate did slightly better at 24 weeks. The second evidence base, which was a randomized controlled trial from China, has since been retracted. So Yugogo recommends a number of second-line agents after intravenous steroids. We know that about 1/3 of patients relapse on intravenous steroids treatments alone. So often they do need something else to maintain the treatment response. One of the popularly used ones is radiotherapy. Again, on meta-analysis, it shows that combined with steroids, it may work better. Azathioprine was studied in the CERTED trial with a kind of 2x2 matrix. They found that azathioprine or radiotherapy didn't particularly help after using 24 weeks of oral steroids, but possibly azathioprine may prevent relapse. A lot of patients withdrew from this trial, and it didn't improve patients' quality of life. Another commonly used one is cyclosporin. Generally, 2 trials have found that dual treatment with steroids was a bit better than single treatment. Another interesting agent is sirolimus, which is widely used in transplant and may have a role in TED because of the anti-fibrotic effect. And one trial has found that it had a better qual and apoptosis diplopia response than intravenous methylprednisolone. So the main advances has been the understanding of the disease. We know that the orbital fibroblast is the target cell, and once it's triggered by the inflammatory cascade, goes on to adipogenesis, increased neuron and myelofibroblast proliferation. And this leads to the pathophysiology of thyroid eye disease with proptosis, the crowding of the apex of the orbit, leading to optic neuropathy and corneal ulceration and double vision as well. So the new treatment paradigm for TED hopes to address both the inflammatory changes and the disfigurement simultaneously, rather than have our patients wait for many years. And it works along different lines of the inflammatory cascade. It's either targeting the B cells, the receptor, IgG recycling, transmembrane signaling, and some of the cytokines involved in this cascade. So I'm going to start with rituximab, which many of the audience may have already have experience, which targets the B cell and causes B cell depletion. So we're all familiar with the 2 conflicting findings of the 2 studies between Mayo Clinic and the one done in Milan. I think the takeaway message is that rituximab needs to be used early in the disease, and Mario Salfi has found that a single dose of 500 milligrams of rituximab may be effective by itself. Another exciting development is actually at the receptor level. So the obvious one to target is the TSH receptor, and KSOT 170 has been found to block the TSH receptor quite effectively in both animal studies as well as humans in this phase 1 trial at different doses of K170. And excitingly, it seems to also reverse the hyperthyroidism, and this subject became profoundly hypothyroid after being given K170. Believe this is in our phase 2 trial in Southeast Asia, and we shall await new developments. But a lot of publicity has been actually not on the TSH receptor, but the adjacent receptor, which is the insulin growth factor 1 receptor, because it's found to be co-located. And you can see in this study by Krauss that actually, if you block the adjacent IGF-1R receptor, it also blocks the effect of the TSH receptor signaling. And this is the basis of teprotumumab or Tepezza, which is a partial antagonist of the IGF-1R receptor. This was a drug developed initially for the treatment of solid tumors that was repurposed for the use of thyroid eye disease. And the phase 2 and phase 3 results surpassed all expectations. The drug was fast-tracked through the FDA for treatment of acute thyroid eye disease, and it has been the original company has been sold for a humongous sum to Amgen in the 2022. So if you look at the pooled data from the phase 2 and the phase 3 trials, you can see that roughly about 2/3 of patients respond, and actually it seems to differentially target the worst affected eye. You can see very, very impressive looking results compared to placebo. And at 51 weeks, with a year after the final dose, this response was maintained in roughly 2/3 of proptosis responders and about slightly under 70% of double vision responders. And what is exciting is that in the extension trial, they found that patients with a longer duration of TED also responded with a similar efficacy as the ones with acute disease. And since then, teprotumumab or Tepezza has also been approved on chronic disease. So you can see this is an example from a publication, and it creates more or less a medical orbital decompression. And the rationale is that there is a chronic recycling process that goes on in chronic disease that teprotumumab or Tepezza is able to disrupt. So this has never been compared head-to-head with IV intravenous methylprednisolone. So on meta-analysis, teprotumumab should be more effective, but again, as I said, no head-to-head trials to date. So the third criteria is how safe is it? We know it's very teratogenic and could cause significant hypoglycemia, but the main concern is hearing impairment. Hearing impairment was not originally particularly studied in the initial trials, but subsequent studies have found that 4 out of 5 patients who received the drug in one cohort study experienced hearing issues. And Tepezza or Amgen has been the subject of many class action suits in the USA, which is the only place, apart from Brazil, which teprotumumab is licensed for use. However, teprotumumab is a real disruptor because it's challenged our fundamental assumptions about the disease. For example, in this study, it shows that not only the eyes reversed and the proptosis reversed, but also the facial fat pads also improved after Tepezza treatment, which shows that actually TED is an oculofacial disease, not just an eye disease. Also, we are all brought up on Rundle's curve. It's very comforting assumption that the eye disease kind of reaches a peak and then burns out. And so some patients may reactivate, but everybody trundles along a very stable course. And we should treat because we can affect it in the early stages. But now, given that Tepezza also affect the disease in the chronic phase, we can think about Rundle's curve rapidly disappearing. So there are many, many new products which are fast on the heels of Tepezza. One is the Viridian 001. This is a complete antagonist, which is specially designed for thyroid eye disease. And the results from the phase 2 trial has been pretty exciting in reducing proptosis and double vision. And the phase 3 trials are currently running in the UK and worldwide. Another exciting agent working along the same pathway is linsinitab. This is again a repurposed tumor, oncology agent, which is actually orally administered, and it targets the intramembrane cycling of the IGF-1R pathway by stopping tyrosine kinase, as opposed to the monoclonal antibody binding outside the cell. So again, we hope that we can get results quite soon from the phase 2 trials. Another area target for treatments is the concept of immunoglobulin recycling. This is something which is widely used already in myasthenia and idiopathic thrombocytopenia. And we're talking about the FCN receptor, or the neonatal FCN receptor. This exists initially in the placenta to facilitate the passive humoral transfer of immunity from the mother to fetus, but it actually persists. And there are 2 agents which are currently in trial looking at this. However, the FCN receptor also exists in adulthood to prolong the longevity of many immunoglobulins. So interrupting this process means that we have less immunoglobulins around, and bactoclimab is a complete inhibitor of this of the FCN receptor. And this was the results finding on a phase 2 trial. It had less than 50% proptosis change. However, they found that the muscles may have decreased slightly in an MRI study. However, the trial had to be halted because of concerns about hypercholesteremia, and there have been no updates since. Another area for drug development is cytokine blockade. As you can see, many cytokines are involved in the inflammatory cascade in the TED. So one which has been repurposed for thyroid eye disease is tolizumab, which is used in rheumatology. And there's been 2 trials looking at patients who have failed steroid treatment and had shown promising results. And this is an IL-6 antagonist. And you can see, again, a second study showing some response with tocilizumab in patients who have failed steroids. And currently, there's a drug trial running with IL-6 inhibitor called satralizumab, again, targeting the same pathway, and again, in phase 2 trials. So we don't have any efficacy data yet. Another cytokine blockade is LASN-01, which binds to the IL-11 receptor, which works adjacent to the TSH and IGF-1R receptor, and again, hopefully stops the inflammatory cascade. So in summary, the targeted treatment works via B cell depletion, recycling, cytokine blockade, transmembrane signaling, and the currently most hot one, which is the receptor antagonist. So we look at how effective is conventional treatment. Conventional treatment, we know, can prevent visual loss, incomplete response against diplopia, incomplete proptosis, well, little proptosis response. We know about safety issues, don't make our patients happy. New treatments, we don't know about visual loss. It should work, but no trials have been done on visual loss. Double vision seems to be better. Proptosis, definitely. Safety, we don't know yet. Tends to make our patients happier, often certainly on treatment, but we don't know the longevity. So targeted versus conventional treatment, what's the elephant in the room? Money. Basically, steroids are cheap. And targeted treatment, currently, I think rituximab retails for about $15,000 per vial in the USA. We're talking about 8 vials of treatment. So treatment comes to about $300,000 to $400,000 US. So it's, very, very different between conventional treatment. But we risk entering a 2-tier world in which the new treatments are only available to those who can pay. For those who are interested, this is a review we published recently. It's open access. These are the trials currently running in the UK. I'm running several of these. So for those who are interested, please contact me. Going forward, subcutaneous oral agents, intraorbital agents are in development. Hopefully, we are looking at new targets and gene therapy. And finally, I'd like to thank all my MDT colleagues, many of who are listening, and most of all, my patients, and for you who listened. Thank you.
Okay, so this is the feedback link for the thyroid masterclass. This is the feedback link for the thyroid masterclass. So please use your phone to take a QR code picture of this. And all you need to do is put feedback in for the talks that you've seen. And then you will shortly, if you put your name and email address on, you'll be able to shortly afterwards, within hopefully about 5 minutes, receive a certificate of attendance. Thank you.